Good afternoon, all the students present here. Good afternoon, sir. So is the extended EDIC Part 1 crash course, and today we will be covering domains like nutrition and general topic. So, it's up to you. You can start. And aspirants, this is going to be a very interactive session. You can also unmute your mic or you can also write in the chat box. Thank you. So you can start the lecture.
Yeah. So, good afternoon, student. Today we will talk about metabolic and nutritional uh, domain, and so there will be some K type and some A type question. Uh, Now, nasogastric tube and nasojejunal feeding tube. So it's a K type question. You will put your answer in the chat box and yeah. So enteral nutrition is associated with reduced risks of bacterial and toxic translocation, gastric residual volume 200 ml, increased risks of reflux, aspiration, and feeding should be stopped. NG feeding is indicated post gastroesophageal surgery. NG tube should not be passed further more than 65 centimeter, and NG tube are easily placed. So, student, please give your answer. You can use the chat box. The answer is enteral nutrition associated with reduced risks of bacterial and toxic translocation, gut in it maintain gut integrity. There are large style on the gut microbiota, and it has been found that if the patient is in NPO status for more than 48 hours, there is a breaching of the gut microbiota, and which help in translocation of the bacteria in the system. That's why there is a production of infection or inflammation. And regarding the large volume gastric residual volume 200 ml, whether you will stop or not, the guideline says that if the gastric residual volume more than 500 ml, then you can pause the your next feeding, and you can add some inotropics, some prokinetic drugs. The drug of choice here is the erythromycin, but remember, we use Reglan, but metoclopramide is the drug of choice as per the European standard. Next, coming to NG feeding is indicated post gastroesophageal surgery. Yes, it has been recommended that early feeding, even the post Whipple surgery or post gastric gastrectomy, and also in acute pancreatitis, early gastric feeding is recommended. Then NG tube should not be passed further more than 65 centimeter. So here it is recommended that if you are entering more than 65 centimeter, there is a risk of complication. So it is better not to go beyond 65 centimeter. And NG tube is easily placed. No, not always. And regarding the confirmatory test, there might be asked what will be your confirmatory test for whether this one in the right position or not. So that will be the chest X-ray is the confirmatory position. Now coming to the next regarding the critical care nutrition, the commencing enteral nutrition within 24 hours of intensive care admission is associated with significant reduction of mortality. Yes or not? And trophic feeding compared with full feeding during first week of intensive care admission is associated with worse functional outcome in patient with acute lung injury. Option C, during the early phase of the critical care, protein intake 0.5 per kg per day is recommended. Selenium supplement is no benefit in the septic patient, and the timing of parenteral nutrition description remain uncertain. So, student, you can put your question, your answer. So, you are saying first one is the Shufokazi Dalkin said that for option A is false, option B is right, option C is false, and then two right. So actually, the enteral nutrition within 24-hour intensive care association with significant reduction mortality. No. Yes, you are right that enteral nutrition within 24-hour initiation, it has no mortality benefit. Uh, though there is a, it has been shown that the early enteral nutrition, which reduces the calorie deficit, which reduces the morbidity, but there is no mortality benefit. Topical feeding compare full feeding during first week of intensive care admission associated with worse functional outcome patient with acute lung injury. No, it has been shown that the patient. There is the question is little tricky. The statement is little tricky. Worse functional outcome. No, tropical feeding is now it's recommended that when you are first you calculate your calorie requirement of the patient and then calorie and protein requirement and then try to replacement this requirement first. Uh, it should be 25% of the total requirement in the first day, 50% in the second day, 75% in the third day. Then you go for a gradually incremental dose. It is a this is called trophic feeding. So it has been found that if you go by the trophic feeding in gradually incremental dose, it reduces the complication like your refeeding syndrome. What happened in the refeeding syndrome when the patient is fasting, because most of the critically ill patient, they are to some extent they are fasting, their electrolyte abnormality is there, and when you are putting the full diet on them, what happened? There is a severe insulin surge, and this severe insulin surge causing the potassium ion to be going to the shifted to the extracellular fluid to intercellular space. So what happened? There is a severe hypokalemia. This hypokalemia can cause cardiac arrhythmia and it might cause the cardiac arrest. So that's why it is recommended not to give the full feed in the first day. So what are the scale or what are the the scoring system to identify the malnutrition is the well recommended and well accepted scoring is the Nutrit score or the mass score, or in a crude method is arm circumstances. You can measure and you can find out the calorie deficit of the patient and try to fulfill within the 4 to 5 days. During early phase of the critical care, protein intake 0.5 gram per kg per day is recommended. No, it is protein is always recommended 1 gram per kg per day, And in certain circumstances where protein intake you have to increase, like if your patient on dialysis, if the patient on dialysis, you have to give extra protein. But when the patient is in AKI or sepsis situation, you can you can't reduce the protein intake, but you can continue 1 gram per kg per day. Regarding the selenium supplement, is showing that selenium supplement is of no benefit on the septic patient, but there are certain situations where the trace element has a good effect. One is your selenium in septic shock, other is glutamine in the burn. So you have to see the recommendation on your micronutrient supplement. You can follow the ESPN guideline, uh, which is standard for this exam. So you download the ESPN guideline and you quote all the recommendation. You will get question from there. Now coming to the timing of parental nutrition prescription remain uncertain. The option is true. Why parental nutrition remain uncertain? So the parental nutrition is not recommended initially, but if your patient not able to maintain the nutrition by enteral route, then you can shift it to parenteral nutrition. Or parenteral nutrition not advise patient who expect to have soft critical care stay and likely resume intake within 5 days and